Bem-vindos a mais um episódio do SOBEDCAST. Meu nome é Vitor Arantes, sou presidente da Comissão Científica da SOBED e hoje tenho a honra de entrevistar o Dr. Mohamed Othman, que é professor da Baylor College of Medicine in Houston. So, Dr. Othman, welcome to our SOBEDCast. It's a pleasure that to have you with us here in this project, and we would like to discuss about the complications in therapeutic colonoscopy, especially perforation.
Thank you so much for this nice invitation and to talk to the members of SOBED. It's a very interesting topic to me, and especially for anyone who's doing therapeutic endoscopy. This is a high-risk procedures that may lead to perforation, and no matter how good you are or how perfect in your endoscopy, you will encounter a situation that there might be a perforation or microperforation, and we should be prepared and learn how to manage it.
Yes. So I'd like to divide our conversation within three possibilities.
Yeah.
The average endoscopist fears to have a perforation in the colonoscopy, like in a diagnostic procedure, for a patient with some adhesions or some difficult anatomy. How we manage such kind of perforation?
Yes. I think in training, and all of us remember these moments during screening colonoscopy when perforation would happen either by the actual tip of the endoscope or the shaft of endoscope, and then your anesthesia team or the nurse in the room would tell you patient is not doing well, they are tachycardic, they are hypotensive. You quickly pull the endoscope out and call the surgeon and hope that everything will go well. In my opinion, this is part of the past, and I will explain why this is part of the past. So what we learned with time is that when we are using air insufflation instead of carbon dioxide insufflation, the air will leak from the colon through the perforation into the peritoneum. The peritoneum will start expanding, causing what we call pneumoperitoneum. And when you have too much air, so what's happening in this situation, you are not able to see very well. You put more air because you want to see what's going on, and that air will go out in the peritoneum. Then later on, the patient cannot breathe anymore because there is no space. So the tidal volume decreases, and all the hemodynamic parameter start to worsen, and this when either the patient code or the anesthesia tell you have to stop right now. Surprisingly, you pull your scope out, you're not insufflating air, they intubate the patient, the patient do well, but you are so shocked and so terrified about what happened. Well, what happened can be managed easily by just putting a 14 gauge needles, two in a location which is 2 finger breadth under the costal rib, and that needle will get all the air out, and then you are not going to have tension pneumoperitoneum, and then you can continue doing the procedure. So if there is anything for our listener to this podcast that they can learn from that podcast, that learn how to manage tension pneumoperitoneum. So always check the patient. Once you feel that they are getting tense, you should have a long 14 gauge catheter, and you will put it, if the patient on their back, you're going to put it around the umbilicus, above or below umbilicus. If the patient in their left lateral side, his side will be towards you, you will see where the rib ends, and you just go two ribs, two finger breadth under that, and you put your needle. Some people worried if you do that, am I going to puncture the organ inside? You will not, because you have tension in the peritoneum and the wall is so far away from the liver, and the moment you will put it, you're going to feel the relief right away. You're going to hear the hissing of the air sound going outside. You also might even consider having a syringe with some water. You put it above the catheter, you can see the bubble, or you can use a very thin paper and you can see it going up and down. So there's many ways to even know, and right away you're going to see that the patient is not as tense anymore. That maneuver by itself, that any endoscopist can do, whether average or experienced, will at least prevent the patient from becoming hemodynamically unstable and will allow you to think about what is going on. Next step for average endoscopists, once you do that, is to think, how large is this perforation? Is it something I can manage or something I can't? And we look at the size. If it's microperforation or 1 centimeter perforation, most of the time you can use clip to close it. And if it is very large, then you have to think about other things, if there's a fecal contamination or not. and quickly you want to suction all the fluid around the area, keep the area clean to think about the next step of management.
All right. And in this case, you would add a distal attachment to the tip of the endoscope. What kind of clip you would use? Could you give us some tips how to manage this difficult situation?
So mostly if we're doing therapeutic procedure, we'll have the distal attachment for EMR or ESD, but during screening colonoscopy, unfortunately, we may not have that. And I feel if you have a perforation during screening colonoscopy and you don't have a cap, I wouldn't go out and put cap again, because you don't want to allow the area to get contaminated, and you want to close it quickly. I always say this: any closure better than no closure. So even if you close the patient minimally, and that will decrease the contamination, is much better than leaving it completely open and send the patient urgently to surgery. Having a cap, though, is very beneficial, because to allow you to see the edge of perforation, and then you can put the clips and to close
All right.
it.
So let's say to our listener that the first attempt for a perforation in a diagnostic colonoscopy, first decompress the abdomen, stabilize the patient, and try to clip the defect. Would be our first attempt.
Yes.
All right, so now let's move to the second scenario, that we are doing a EMR or even a ESD in the colon for a colorectal lateral spreading tumor, and then you end up with a perforation, let's say 5 millimeters or 10 millimeters in size. How we manage this situation in a therapeutic procedure?
Yes. So sometimes we also have fibrotic lesion that when you dissect, even no matter what you do, the wall will come with you and you will have a perforation because of the severe fibrosis. So the first thing is to continue dissecting till you have this margin free. A lot of people, once they see a microperforation, they will quickly put clip. And if you quickly put clip to close the area, it will interfere with the dissection. Also, I notice that certain people, once perforation happened, they'll say, that's it, perforation happened, cannot do for ESD, give me a snare, I'm going to finish the procedure right away, and I'm going to come out with my endoscope. We'll go back to the idea of tension pneumoperitoneum and putting a needle. You have to continue dissecting, and if tension pneumoperitoneum happen, you would put the 14 gauge angiocatheter. In this situation, if the patient are intubated, and usually they are intubated for ESD, or at least we should encourage doing that, you would like to look at what we call peak inspiratory pressure, and tell your anesthesia providers that we are looking at the peak inspiratory pressure, so do not change the tidal volume to maintain it. And then you're going to see that the peak pressure for most of the patients who are intubated is between 15 to 25. And once the peak pressure jump up a little bit, 5 points more, you know that the air is going in. When you are dissecting, you say it is the time to put the angiocatheter, you put it and dissect enough so that you can clip it without interfering with your dissection. But you also don't want to wait too long till the peritoneum get contaminated. In this situation too, the size of perforation matters in terms of what else we can do. So for a larger perforation, areas that larger than 2 centimeter, I know for sure that there will be soiling. And since it is that large, your endoscope can easily go through it. I would go to the peritoneum, suction all the content, and even use saline for irrigation to prevent peritonitis later on. And doing so will help that this patient will not have irritation, and also you're going to absorb all the smokes that come from the dissection, and then you start closure after that.
Okay, so in a therapeutic procedure, just summarizing, first you continue the dissection to expose better the defect, and then of course paying attention to the abdomen. If there is no tension, no peritoneum, in this case you would do like we did before, like the descompression, and then attempt clipping after you have proceeded with some dissection and shown the defect and have a good space for the clipping. Is correct?
Correct.
Okay, so now we have a third scenario. We did a EMR or ESD in the right column, apparently successfully, and the patient in the postoperative period present signs of perforation. Acute abdomen, with pain, with perhaps peritonitis like 24, 36 hours after the procedure.
Yes.
Is there anything endoscopists can do at this stage, or how we manage this situation, which I think is the most critical one?
Yes. So in this situation, there is two things going on, and sometimes it's very hard to distinguish them. One of them is post-coagulation syndrome, and the other one is actually post-resection perforation, delayed perforation. So how can we differentiate delayed perforation from post-coagulation syndrome? So for our listener, what is post-coagulation syndrome? When you resect large surface area and you leave it not very well closed, or sometimes you leave it on the muscle layer, the inflammation that happened in day 2 or 3 comes to serosal level, cause fever, abdominal pain, but there is no actually frank perforation, but it almost looks like microperf and appendicitis. And in this situation, you give them IV fluid and antibiotic, and that would be enough, and the patient will do well. But sometimes if you have a perforation that's actually frank perforation with fecal contamination, that's when you need to take the patient to the surgery. So in this situation, I like to do CT scan with oral and rectal contrast to see if there is any extravasation of contrast material. Anytime we see extravasation of material, then we'll have to have exploratory laparoscopy and cleaning the peritoneum. And also in this situation, you would like to maybe leave a drain, or sometime of the areas very contaminated, patient might have hemicolectomy, and in very rare situation, they might need to have a colostomy or ileostomy. So in order to prevent us from going into all these situations, that's why in right side colonic lesion, I'm very advocate of closure. And a lot of people would say we don't need to close everything, and I agree that we don't need to close everything. But if you spend 2 hours using cautery and coagulation to dissect in right side of the colon for an area that more than 4 or 5 centimeter, most likely in every 15 to 20 case, you will have a patient who come to the hospital with abdominal pain. And if you have a good closure, you can reassure everyone that this is just post-coagulation syndrome. And even if delayed perforation happened or something, the area is closed, it will be minimum, and antibiotic and IV fluid would be enough. But I agree with you, this is one of the most dreadful situation, and I feel we don't have enough studies yet showing that closure decreased that, but by experience, we know that if we will close these areas, that situation doesn't happen as often.
All right, so then we comes to the discussion about how to prevent. You just introduced it, how we can prevent this delayed perforation to happen. So I would like to ask you first, what is your criteria when you decide, okay, after I finish this resection, I want to close? So what are the patient condition or even the size of the defect? What criteria do you use to indicate the closure, and how you perform this closure? What are the devices that you use? What is your preference to close those defects?
Yes, that's a very controversial topic. But so whatever I'm going to say right now is only my personal opinion, and I'm sure a lot of experts in the field will have different feelings about it. But I would like to let our listeners know that I do high volume of colonic ESD, maybe 5 to 8 a week. And when you do that high volume, you will have a very different scenario than someone who is doing it not as frequent, because when you do it that frequent, you are the one who are going to get the complication and adverse event. And when you do it in that continuous basis, if you don't really prevent this adverse event, people will start wondering what's going on with your outcomes. So I learned with time that all right-sided colonic lesion should be closed. And I know this might not, a lot of people do not close everything in the right side, but I would say if you are able to close it, you'll close it. If you are not able to close it, then you have to do good inspection of the area and make sure that if there is anything of microperforation or even muscle cut, you can close it. There is a classification that I like so much called the Sydney classification. And the Sydney classification was done for EMR and also for ESD. I think it's Dr. Michael Berg group, and they did an excellent job on identifying how to look at the post-resection bed. And if it is just like a small disruption in the muscle layer versus deep disruption, but you have the serosa intact, versus the serosa is open and you can see outside, versus a fecal contamination happening. And obviously, anything that you feel like level 4 or 5, it has to be closed. If you only have muscle injury, and then it's debatable, you can leave it alone or you can close it. But let's talk about what if you decide not to close. If a large area, I feel it is impossible to close. Admission with IV fluid and antibiotic and observation will prevent the post-coagulation syndrome and maybe prevent delayed perforation syndrome too. And that's, if we notice Japanese, they admit patient for 4 to 5 days post-procedure for that reason. Obviously, this will be costly, and that's why I feel the cost of closure will be cheaper than the cost of admission and observation in this work. But there's certain situation it's impossible to close. So if you remove 90% circumferential, you will not be able to close. There are new agents like self-forming like peptides that you can put in the surface. A lot of people are using them now, but we don't have still evidence that it prevent post-coagulation syndrome or even prevent bleeding post-procedure. I feel we need to do more studies, multi-center studies about that. And the problem, these studies requires large number of patients, and one institution will not be enough. But post-coagulation syndrome is real, and I tend to close most of my colonic lesion. I tend not to close in the esophagus because the muscle is so large and coagulate. I may not close in the stomach, although I also can close because of the acidity in the stomach. Any duodenal lesion, I always close them for sure. And right side colonic lesion, unless it is impossible to close, I will close them. Having said that, I know other people may not agree with me on this.
So I think this is very critical information, and I will repeat that to our audience. All duodenal lesions that you perform EMR ESD, all right colon lesions, some lesions when you have a damage to the muscle layer, and very seldom in the esophagus and stomach. Is that correct?
That's correct.
Very good. So now I would like to make a final question. We are in the right column, we did a large EMR or ESD, you decide to close it, and it's a defect like 5-6 centimeters in size. How is your strategy in closing it? Do you use standard clips? Do you use different suture methods? How do you choose, pick up one or another device for this closure?
Yes, so I have been doing many studies in closure because this question a lot of time is bothering me and you and others about what is the optimal and also I would say economically efficient way, because you can use many devices but you end up spending a lot of money in the closure and a lot of effort and time that you might take almost the same time you used for resecting the lesion to closing the lesion. So I think about the closure as two steps. First step is edge approximation, and second step is actual closure. And in the market now, we have many devices that I consider them approximating the edges, which you can put it in one edge to another. And once the edge gets close enough, you can easily and quickly put clips. And we had a recent study that we looked at the closure time, and the closure time in some of these new devices could be up to 10-15 minutes in 5-6 centimeter area, versus in the past it used to take me 30 minutes to 45 minutes. We cannot suture in the right side unless we have certain over tubes that allow us to the suturing device. So in the right side it is still clips and the new tacking system that can make edge approximation. And there are new clips that have dual actions, which one side will open, you bring it to the other side, and that's also will cause edge approximation and will enable the closure. Anything in the sigmoid colon and the rectum, if I would like to close, I feel like suturing is fast and efficient. And if you are trained in suturing, this can take maybe 10 minutes, no more, and you will have a good and reliable closure in a very quick time. But clips there an art to using them, and I feel one of the major problem we had with using clips if the edges are too far, and not everyone is experienced enough to place the clips as they should to bring areas together. And I feel that tissue approximation devices are helping us in this matter. So I feel like closure field is really evolving too, and it will be much easier to close, and people will start to feel like, yes, I can close this area. I don't have a problem, waiting for 45 minutes to close it, so I will close it if I can do it in 15, 20 minutes.
All right. So as a final message to our listeners, could we say that the therapeutic endoscopist need to have in his toolbox more than the standard clips, start to getting familiar with the different devices that we have now, and maybe a combination of them would be the best option to close these large defects?
Yes, so I had to go through the struggle with my hospital a few years ago. They got so annoyed why you have too many types of clips, and why you are ordering this and this and this, we're not using one clip like all the other doctors. I had to make a video of one of the lesion and how closing it, to explain to them that if you have a resection program, it's not about one clips fits all. Actually, and this could be a topic by itself, we can talk about each clip and what it's good for and what you can use it for. And each and every case, I use a combination of 2 to 3 clips types. And in certain cases, I know that type of clip will not work at all. So yes, I totally agree. Resectionist should know how to use different type of clips and should insist on having them in their unit, even if their hospital told them you can, and they should link it to patient safety and patient outcome after that.
Very good. So, Dr. Othman, I think this was a very educative podcast. We talked since the diagnostic the perforation that happens in the diagnostic procedure up to the perforation that happens in the therapeutic procedure and how to prevent it. And so thank you so much for participating in this project. We really appreciate your contribution to our Brazilian Society of Digestive Endoscopy.
Thank you so much for inviting me.
Thank you.
Thank you.